Hello, this is Jason Williams from Proceduralist.org, and today we're going to review lumbar puncture. Take a look at the previous chapters on Proceduralist.org for more information about complications and contraindications. But briefly, before the procedure, be sure to obtain informed consent and tell them about the risks of complications. Consider ultrasound guidance, especially when it's difficult to palpate landmarks in obese patients, those with severe degenerative joint disease or osteoarthritis or previous back surgeries. And be sure to always perform a procedure timeout. In addition to assuring that you have the right patient and are doing the right procedure, make sure they don't have an allergy to lidocaine. And check one more time that there's no contraindications to the procedure, including indications for head CT, risk for herniations, and most importantly, significant coagulopathies or therapeutic anticoagulants like Coumadin or therapeutic Lovenox, which are known to cause markedly high risk of spinal hematoma and paralysis. Next, patient positioning is key to the entire procedure. Uh, the lateral decubitus is preferred because you can get an opening pressure in this position, but sitting often has an increased success rate because it opens the spinous processes more widely and skin folds are aligned. And sometimes in obese patients, the midline appears to shift as the skin sags, and this doesn't happen in the sitting position. In either position, rolling the shoulders forward and pulling the knees to the chest is critical to maximally opening up those spinous processes and increasing the space to pass the spinal needle. This is actually a poor example of the sitting position. To optimally open the spinous process, a chair should be brought to the foot of the bed and the patient should rest their feet on the seat of the chair. Then a pillow can be placed on the patient's knees and then the patient can lean forward and rest their arms and torso on the pillow in their lap. Alternatively, if the patient's unstable in this position, can remove the chair and instead place a bedside tray for them to rest their torso and arms on, but this does not quite open the spinous processes as much as having them rest their legs on a chair. This is another common example of poor positioning in the lateral position. You really need to have the shoulders and the hips in proper perpendicular alignment. You can see at top the optimal position is having nice perpendicular alignment of the hips, shoulders, and spine to the bed, which can be aided by placing a pillow under the patient's head and a pillow between their knees. That would prevent the curvature seen in the image below. Once the patient is positioned, next palpate for the iliac crests. The superior aspect of the iliac crest corresponds with L4, and that will be your major anatomic landmark. L4 is well below the conus medullaris, and you have options of inserting the spinal needle one spinous process above L4 at the L3-L4 junction, or two spinous processes below L4 at the L4-L5 or L5-S1. Generally, the further down the spinal column, the wider the space between the spinous process, but the further down you go, the deeper the bones are and the more difficult they are to palpate. So you can insert in any of these levels depending on what you can palpate the best. Once you've decided, be sure to mark the space with a Sharpie or more preferably a surgical marker. Next, sterilize the area with one large ChloraPrep or two smaller ones, at least an 8-inch by 8-inch area. Then wash your hands and don a face mask. You can then open the kit in a sterile fashion and apply your sterile gloves and sterilely drape the patient. Next, organize your lumbar puncture kit, including opening your 4 tubes and noting which ones are 1, 2, 3, and 4 and being prepared to fill them in order. Then proceed to numb the area with lidocaine, first with a wheel and then deeper into the sub-Q tissue. Now you can take your spinal needle with the stylet in place and take a 15-degree angle approach, aiming towards the umbilicus. Also critical is the orientation of the bevel. It should be in the sagittal plane or horizontal and parallel to the spinal canal, and this will spread the dural fibers as seen here, as opposed to cutting the dural fibers, which will increase post-LP headaches. As you advance the needle, you'll pass through the skin and subcutaneous tissue, then denser tissue, including the supraspinous ligament, the interspinous ligament, and then you'll encounter the ligamentum flavum, and as you pass through this ligamentum, you'll feel that classic pop, at which point you should withdraw the stylet and look for CSF. If there is none, replace the stylet, advance the needle 2 millimeters, and remove the stylet and look again. Replace the stylet in advance if you still do not see CSF, and repeat as necessary until you enter the subarachnoid space. As a reminder, the bevel of the needle should be in the sagittal plane as shown here, which is parallel to the spinal cord and nerve fibers, which spreads the dural sac as opposed to cutting it. And this again has been shown to reduce LP headaches. Once CSF is flowing, use the stopcock to attach the manometry tubing to the spinal needle, and watch for the column of fluid to fill until it plateaus, and there will be some respiratory variation. And note the highest peak of the CSF. Remember that the white stopcock always points to off, so you can see the white stopcock pointing to the right in this direction, which allows CSF to flow in out of the spinal needle and up the manometry tubing. And once you've noted the opening pressure, turn this white stopcock all the way to the left, and that will allow you to drain CSF from the manometry tube into your tube number 1. Once you've finished collecting CSF, be sure to replace the stylet before pulling out the needle. This has been shown to reduce post-LP headaches. Apply mild pressure, remove the dressing, and add a Band-Aid. Be sure to dispose of your sharps and properly label your CSF specimens and get them to the nurse to be sent to the lab. Be sure to write a procedure note for all the procedures you've done, whether successful or failed. And that's that.